Good morning, everyone. Thanks for joining us this morning. We're excited for a new webinar for us. I've got Steve Kershke in the studio with me this morning. Just a reminder, at towards the end of the presentation, there will be a poll question. Make sure you do answer that poll question. That's how we gauge who we're going to be sending the CU certificate to. And yeah, we're going to go ahead and get started here. Steve, welcome back to Studio Q. You're a veteran here now.
Thanks, Tim. Welcome back to work. You've been working from home.
I know I have. Yes, it has been chaotic at my house with my kids. So, but it's good to be here. So, Steve, new topic for us today: effective treatment of limb loss. Not a new specialty of ours, but definitely a new webinar topic for us. So,
Yeah, definitely not a new specialty, but it's part of the reason we did this is many of our payers were asking us to address limb loss maybe a bit differently than what we have in the past. We've always we definitely have the competency in place, but normally when we see these types of individuals, they're paired with some sort of other complex injury like a brain injury or spinal cord injury. So we end up getting the most complex of the complex, and as a result, we started getting requests to see just limb loss, and so that's been an exciting
definitely.
project for us. It definitely allows us to do some different things and maybe to a different speed and intensity. So that's been really fun to see.
Absolutely. And you're kind of diving in lately on doing tele-rehab sessions as well, right?
Oh
I know you're
yeah.
going to talk a little bit about tele-rehab on this. So,
Yeah, I've been flexing my therapy muscle. Haven't done that in a while.
for those of you that don't know, Steve is an acting PT. So it's been good to hear and watch him get back into that because you can definitely tell it's a passion of his. So,
Yeah, the tele-rehab team didn't think I could do it still, so I had to show them up.
well, you want to roll? Get started on here.
You bet.
All right.
So when we think about treatment of limb loss, maybe. All right. So when we think of treatment of limb loss, really we've tackled this much like we tackle a lot of our folks with brain injuries, spinal cord injuries, and other complex injuries. We look at this, and when we stepped back to prepare what a program might look like and put together, a curriculum of sorts, we did it through a lens of a center of excellence, and we also did it from the standpoint of how do we get in touch with these individuals from the very start of their recovery journey, and how do we keep in touch with them all the way through the recovery journey, hopefully till the end. And so this presentation really outlines that, and what we think it does is it provides a really structured approach at every phase, and in doing so, I think it helps facilitate and coordinate things maybe a bit differently than what we're used to seeing with these types of individuals. I think traditionally, these individuals have really short stints of a hospital stay, pretty quickly transition to outpatient therapy. And that outpatient therapy is really driven towards mass practice, and it's driven towards maybe some less than functional goals and less than functional activities. And so, as a result of that, I think it leaves these folks coming up a bit short as to their progress and really their emotional health and just satisfaction with their life after an injury like this. So, that's the lens that we looked at this through. And those of you who are familiar with how we do things at QLI, it probably doesn't sound much different than how we look at other things that we tackle. So, it's been really fun to try to apply that to really somewhat of a different population. Sorry, my thing's not working here, Tim. So, just to highlight again, why we feel like this is a good approach. First of all, a lot of the feedback we were getting from our payers was that costs of treating these individuals was rising very, very quickly for a couple reasons. One, there was no methodical way to go about doing this, and there really is not always a specific decision making process when it comes to the type of prosthetic, when to get the prosthetic, as well as some of the other comorbid factors that we consider when we're dealing with these individuals. So obviously keeping costs down is a nice motivator for everyone. And again, in doing so, I think by streamlining the clinical decision making process and the prosthetic device selection, it does have a direct effect on the cost, but I also think it has a direct effect on the outcome. And, we really want to make sure that these individuals get to a high level of recovery. And the way we look at it is these individuals, for the most part, can get back to a pretty um, baseline level of functioning as to what they were doing before their injury. Now, it might look a little bit different. Maybe they can't get to the exact same job that they were going to. So I don't want to overstate that, but you can definitely get a really great recovery from these individuals just, for a lot of reasons. But that's not to say that these cases are not complex. There's lots of different factors that can come up. When the wounds are healing and when all those factors at the very beginning are top of mind, that can be very challenging. And then, to that last point, I really think the emotional coping and resilience piece of this is something that gets overlooked or it gets looked at late in the game. And so, they go through the surgery, they get their amputation, they start to get along the process of getting their prosthetic, and then we might start to think about the psychological and the emotional recovery portion of this. And I think there's really a better way to do that. So something to be thinking about as we move forward. And, no surprise here, everything that we're doing is really trying to connect our therapy to the person's life. And I think what happens a lot of times is if we look at just the therapy in a hospital or just the therapy in an outpatient clinic, we miss all of the other real world things that are going on once they get back to their home or to wherever they're going. The other thing is that it's sometimes hard to connect to those activities that we're doing in a hospital or a clinic to something meaningful and engaging. And so, looking at it from that perspective, I think really shapes the approach and it shapes the effectiveness. So we break this up into 4 phases. So the first phase doesn't necessarily even um, pertain to QLI and our team at this point. Usually, we would be getting maybe word of this potential referral, but it starts with an acute hospitalization, and the person probably has some sort of catastrophic injury that is going to lead to some decisions around whether or not to take it towards an amputation. And so there's some pre and post surgery planning. You're probably starting to look at, what does the overall rehabilitation plan look like? Hopefully, we're thinking pretty long term about this and trying to understand, is an extensive hospital stay going to be necessary, or can this person pretty quickly move through the hospital to outpatient therapy, and then trying to envision even what outpatient therapy looks like, and talking about things like back to work, and hopefully all of those are starting to be projected. Certainly, you don't have clarity of these at this point in time. Maybe a little too early to tell, but I think a good collaborative interdisciplinary plan in place at this at this juncture is a good idea. And then, as I alluded to, I think starting to consider the emotional coping and adjustment portion of this. And that might be even going as far as getting some more formal psychology, impact at this point. The person may not even be ready for this, though, too. So I think we have to take this as an individualized process. But maybe we're starting to ask a few more questions, or at least red flagging some situations that might lead towards some challenges down the road. I think we're all getting better at understanding what are some premorbid factors that might contribute to this. So, is there a history of mental health? Is there a history of relationship challenges, and what's the family structure and what's the network of that person look like, so that we can start to understand how things might be affected from this perspective. And again, what we believe is if you tackle this early, then I think there's a significant impact on down the road. And I think the person becomes even more open to being pushed and challenged and willing to try some things that might look a little bit different than what they had in mind. I think it's pretty obvious that having some sort of amputation is a big deal, um, but finding ways to work through that and make decisions about prosthetics and make decisions about back to work can really get slowed down if we're not addressing this effectively. The other thing I would say is, and I mentioned a more formalized approach with a psychologist. I don't think it always has to be a psychologist, right? It could be another clinician, and it could be a social worker. It could be, anyone in the person's network, especially if they're not ready for that. So we really look at this through a lens of everyone can be that emotional support and everyone can start to guide that. But those people might need a little bit more guidance from a psychologist or someone who's trained. We see that the repetition of this is really important. So when it comes to learning how to deal with this, the more that we can expose them and the more conversations that we can have formally and informally is something that we really strive to do. And I think it leads to some of these extra phases and how we incorporate those into the treatment. So once someone has chosen to, move through with a surgery, there's definitely some pretty straightforward medical things that need to happen. And, when we think about brain injury and spinal cord injury, we look at this through three different ways, right? So you've probably heard about us talking about our tridimensional model. And the first part of that tridimensional model really is just medical stability. And I think that's really front and center here in phase two is these individuals need to be medically stable, medically taken care of. The wound, the extent of the wound needs to be managed, and any pain that's associated with that, start to jump on that right away and help these individuals understand what causes pain. So I think pain education is a big component to that we talk about. But beyond the pain education, it is, maybe some more acute factors to help them manage their pain. The other thing is that residual limb needs to be addressed in order to start to prepare for a prosthetic should the person need one or choose to have one. So any shrinking and shaping of the residual limb, obviously the best way to do this is in conjunction with a prosthetist. So getting prosthetists in on this as early as possible, we feel is helpful. Now, the prosthetist factor can be challenging as you move through the center of excellence approach because sometimes that prosthetist might be local. And in our case, we're not always local. And so collaborating with that prosthetist or getting a prosthetist team in place is something to consider, especially now. So choosing that prosthetist at this point, or at least thinking about that is going to be important too. And then making sure that we're starting to address flexibility, strength, and endurance. So we know that whether it's an upper extremity or a lower extremity type of situation or both, we know that these factors are going to contribute to the person's capability of managing the prosthetic as well as completing some functional activities with it. And so if we can prepare them for all of that, even before they get it, then we can jump right into the prosthetic phase a bit more quickly. And then the last factor there is just the independence without the prosthesis. It's definitely an adjustment. So at this point in time, we might be looking at some adaptive devices. They may need a wheelchair of some sort, some shower accommodations, or even home accommodations, depending on if they're going to be going home and where their rehab is going to happen. So, OT and PT are pretty key here, and understanding that, getting a good idea of what their environment looks like is going to be really important, not only for this first phase, but it also bleeds into the additional phases. Phase three, this is, by the way, I guess I should back up. During this phase, the way that QLI has envisioned it is that we would use our tele-rehab services at this point in time. So because we have those capabilities, getting a referral at this point is definitely possible. Our tele-rehab team would take the lead on this. Back to the prosthetist involvement, we can definitely collaborate with the prosthetist, whether they are local or not. We do have some local partnerships that could be helpful with that process. But really, we're able to provide all of this through a virtual environment. And so understanding, how do we manage and address the wound? Certainly, even if we were in person, we wouldn't be managing the dressings and that sort of thing. But, we can monitor what the wound is looking like. Is it healing well? Make recommendations as to consultations with physicians or nurses around those, and same thing with the residual limb size and shape. But more specifically with the flexibility, strength, and endurance, as well as the independence, we put together programs for this. We work with the individual in their environment again because that makes it more functional, and we allow them to manage all of this usually from the comfort of their own home. But they're also likely going into the community, and so when they go into the community, we would be right with them there too, due to the virtual nature of things. So, we really bookend, as you'll see when we get into phases 3 and 4, we really bookend our program in phase 2 and phase 4 with telerehab. And as we get to this next phase here, this is where it could mean an actual visit to our campus. I think this is probably the most polarizing part of it. We always get the discussion. Tim, you and I always deal with this, even on the brain injury and spinal cord injury side. For individuals who don't live in Omaha or in the immediate Midwest, it's pretty common to get the question of why would I go to Omaha? And I think in some cases we're still probably dealing with that with this population because traditionally this population stays local. And the mindset has been, well, I have a physician local, I have a prosthetist local, and I have a therapist local. Those three and the rest of the medical team may have a ton of experience in limb loss, which is great. More than likely, they don't have a lot, and so in those cases, that could mean a trip to Omaha. So.
Well, I think it's important too, Steve, to talk about. They may have a lot of expertise in limb loss, but bouncing back to your emotional support side,
Mhm.
when it's all in one area, it's all being done at the same time. We've just seen better outcomes with that.
Yeah, I mean,
So,
I think the skillful implementation of an interdisciplinary model
mhm.
is something that gets missed. So I think that's a really good point. I think traditionally it's you got PT handling the strength and flexibility and all of that sort of thing. You have your OT managing the functional aspect and accessing the community. You have the physician and the prosthetist maybe working on that residual limb, but maybe they're not even all talking to each other. And
Mhm.
then the psychologist is kind of off in the corner doing whatever he or she's doing.
Yep.
And I think that's a big miss in my opinion, because what we find and how we usually approach even phase 2 is that our clinicians can collaborate. They're all in the same building for one, but even if they weren't, they would be pretty collaborative. Um, and talking about, well, okay, how is this affecting that, and making sure that the right hand knows what the left hand is doing, and that allows us to continue to address and manage things that are already present but maybe things that are popping up along the way. So I think that's a really good point, and I think it takes it to another level when you think of phase 3, right? A lot of times people come to QLI for a comprehensive program, which I think that's great. But in this case, I think I've added the word intensity too. The reason we said intensity is we've envisioned this as a day program. And so individuals would come to QLI for a day program. Granted, they would have to stay somewhere probably. Um, but the intensity that we can provide during that day program hopefully limits the time that they need to stay here in Omaha, and we can get them back home as quickly as possible. So usually we envision this as really like a 2 to 4 week stay. It could happen in a couple intervals too, though, because a lot of times these individuals are working through the prosthetic choice, and choosing that prosthetic can be a multi level process. And so sometimes they might be here, we get them set with that initial introductory prosthetic, they go home for a period of time, and then they may need to come back to get that updated. Or as you'll see in phase 4, we could maybe collaborate with a local provider at that point in time. And so this isn't like a strict linear process. I think it definitely has the opportunity to bounce back and forth between phases 3 and 4. But it allows us to provide a really intense hands-on experience. And then it starts to make it really functional too. So all the things that we traditionally do on the brain injury and spinal cord injury side of getting folks into the community and starting to envision, what a life beyond the actual injury looks like. That is all applied to these individuals through the day program. So we start to establish partnerships with the prosthetists. We're achieving optimal function, but really we're starting to envision what this person's life is going to look like from a hopeful perspective, helping them see that their life can be something gainful and worth living again. And then, identifying that sense of purpose. And for many folks, that's, how do I be a father potentially in this type of situation? Or how do I go back to work? How do I access maybe my leisure activities? So that could be adaptive sports, running, fishing, cycling, all of those things, right? They come with some new challenges and some adaptations that might be necessary. And so we're starting to investigate and put a few things in place during this time. And then I've alluded to phase 4, which again, if you remember back to the bookend comment, this again pulls in tele-rehab. And so we're able to collaborate with the clinicians that the individual worked with on campus, and then um, provide the access to the expertise once they leave and go back into their community. So many of our individuals are coming from outside of Omaha or even Nebraska, and making sure that we can support them once they leave. So it provides access. And then that second bullet there, it provides a level of continuity for them. So hopefully we've collaborated with the prosthetist, whether it's either local to Omaha or local to where they're going back to. And then we've also established some sort of routine that might be going on once they get back. So made contact with their work, collaborated with their family and friends, and helped to put in some routines that would transfer. And then I think the third bullet is almost the most important bullet. Probably no surprise. By the end of this, you're going to be tired of me harping on it. But this idea of therapy happening in the real world is really important. So at the end of this, we do have a couple of case studies and there's a couple of videos. And what we know is that real world training provides a clear picture of the challenges, and it allows us to really tackle those in the settings that they're going to be in. And then this convenience factor, I think I've been amazed at how many people just enjoy being able to click on their iPad or phone and be able to have almost on-demand access to our clinicians. I think in this time of COVID, I mean, there's certainly a safety factor to consider. And I don't know how long that will last. You got to think though that it'll start to shape some folks' behavior long term. So, I think we're really thankful that we are in the tele rehab game way before COVID came about, and so we didn't have to play catch up during the COVID process and figure out how to implement this therapy that is really complex. And so it's been really nice to be able to respond in this way, but also it's going to be interesting to see what happens once, and hopefully once things kind of die down in this realm. And then we see just the motivation factor of our clients to be really high. A, because it's convenient, B, because it's meaningful, and it's tied to their world. And so all of those factors, I think, lead to really great outcomes. Okay, so just a couple case studies. So we have 2 case studies here. This first one is with Yoni. So, and I'm going to try to refer to it in phases. So you'll see here that Yoni participated in phases 3 and 4 of our program. So you'll see that there at the bottom. And so that meant that he actually came to QLI, stayed at QLI for our day program. We worked with him while he was here, and then he transitioned back into his own community after he left, and we're still currently doing tele-rehab with him. So quick background on his diagnosis and situation. So he had a right hand amputation through the proximal phalanx of the thumb, metacarpal necks of the fingers 2, 3, and 4. He also had a shoulder injury that associated with this. So Yoni worked at a butcher plant, and he was, working around, his butcher device. And as he was working, the glove that he was wearing actually got caught, and then he incurred the injury from there, and associated rotator cuff injury as well. So that's how he got it. He's 24 years old, so he's a young guy. Really loves the outdoors, loves to skateboard, loves to go to concerts and play Xbox. Actually, Xbox and video games was a huge thing for him. And so after, his amputation, accessing video games was really huge, and something that was missing. The other thing is he was a father of two young kids. And so really when we did the intake with Yoni, one of the things that he said was that his identity was totally stripped from him. And this really isn't an uncommon statement from many of our folks. A lot of times their identity is really tied to their work or tied to their role as a parent and tied to their role, and how they're seen socially with their friends and some of the leisure things that they can do. So that was a really big deal to Yoni. And he, up to coming to QLI, had been working with a prosthetist that was 2 to 3 hours away from his home. So didn't really have access to that person consistently. His support system wasn't all that great. He also had a pretty substantial history of some mental health. And so the emotional factor was really big too. And so his case manager reached out and asked if we could be helpful. The other thing to think about here is at the point when he was coming to our day program, they were in the process of determining whether or not his current body powered prosthetic was a good fit for him. Like, A, was it the right prosthetic? And B, did it actually fit his residual limb well? There were some discussions about going to a more expensive electronic unit. And so part of him coming to us was to help understand, A, does the prosthetic fit his residual limb the way it should? And B, does he need a more intricate unit? And so that was kind of what the team was tasked with while he was here. And so, the way we tackled this was collaboration with the local prosthetist happened even before he came to QLI. So that meant phone calls with our clinicians. We actually pulled in our prosthetist locally, and we did several conference calls to make sure that we had a good idea of what that would look like. I'll be honest, and this is probably more of a challenge than I expected, but the ego of the prosthetist that was local was extremely high. And I think he was immediately kind of on guard with, like, who are you? What are you doing? And why is he leaving my care? So I think we had to work really hard of gaining the trust of him and helping him understand, like, our position, where we were coming from, also that we were there to support him. And we actually had a lot more information than he had. And so that process was really interesting, and I think our team did a really good job of that. And then, as I mentioned, the evaluation for the need for an additional device. What we actually found while he was here, because we put him through and evaluated everything in a functional way, Yoni actually didn't need a more intricate device. He actually ended up doing more without his device because he was way more functional. But it was this emotional tie to, well, A, I don't want this device to begin with, but this device appears to make me look more normal and have more function. But that actually wasn't the case at the end. And so things like eating, he still had some function to be able to do that. Things like dressing and even some work related tasks he was able to do without his prosthetic device. But then we were able to say, okay, here's a handful of things, if not more, that your device would actually be a great use for. And made some recommendations on there. We're able to get the fit to a point that was comfortable to him. And then establish a more consistent wearing schedule. What we found is his self-report when he came was that he was wearing his device quite a bit. Once we actually saw him in person, there was a big gap with that. And he actually wasn't wearing it at all. He was only wearing it a couple hours a day. And so also we were able to make some recommendations as to the wearing schedule. And if he would have needed a more intricate device, we would have been able to make some recommendations on whether or not his behavior around wearing the actual device lended to him being compliant with wearing a more expensive device. So I think for the insurance company, they got a lot of information from this. It saved them some money on the device, but also, Yoni was actually more functional in the way that we did this. And so, we were able to really help the insurance company in that way, but I think more importantly, help Yoni work through the emotional factors at QLI, transition this back to his home. So right now, just to kind of round the story out, he's living home independently, able to do some parenting and some of those activities with his kids. He's back to gaming because we were able to find some ways to address that. And then he's working with our OT to continue working on the function of his residual limb, as well as working with her to identify um, a volunteer job to go back to, because I think that was the thing that before he came, he didn't have that sense of purpose. He was used to working, and his identity was tied to his job. So we've been working and trying to identify a way for him to do that. He's now driving. He wasn't driving before, so his world has just really opened up in many ways. The other thing that we addressed was just pain management. So he had some sensitivity in his upper extremity, some shoulder discomfort, that sort of thing. So that was all part of it. And then just general strength and endurance. And as I had mentioned already, just the purposeful activities and the employment there too. So something.
Yeah, we had a few questions that came in. There was somebody that asked, you just answered this, but assuming your discussion on prosthetics is specific to lower limb prosthetics, obviously that's not. I think there was just a clarification on that. And then, does our Center of Excellence in Omaha have a full staff of prosthetists, OTs, PTs, an MD, and psychological help?
Yes to all the above, except for the prosthetists. So the prosthetists, we have two local prosthetists that we have a great deal of experience with, good relationships with. They do come to our campus. They also have offices if we need to use them, and they're within just 5 minutes of our facility. So while they're not employed by QLI, very good partners of QLI, they also do make trips to, when they do come to campus, they're able to work right alongside our clinicians, which we see a ton of value in. So whether it's an upper or lower extremity situation, having that prosthetist there to make adjustments to the fit, right in the therapy setting is important. And then be able to trial that and have them walk or have them use the device, tweak it a little bit more, so it's more real time that way. So we find a lot of value, and it's pretty highly collaborative. Beyond that, though, our physician, we do have a medical director that oversees our program, but he's actually more of a partner in the program. It's not very hierarchical, like maybe you see in some other programs. So really, I think he would say he gets the best of both worlds, right? He gets to practice medicine, which he loves to do, and he definitely brings a lot of value. But I think his impact is even greater because he works alongside the clinicians too. So let's just say we need to make a med adjustment, or um, he's trying to understand the mechanism of pain. He'll come to a therapy session and work right alongside our clinicians in the same fashion that the prosthetist does. So he gets a lot of information from our clinicians, and the clinicians are funneling all of that dialogue up to him. And I think the decision making actually is really superior because of that. So
Just quick before we move on, still just some questions pertaining to this exact case here. So, how long post injury did Yoni come to us?
Good question. Let me think. It was years post injury, so I think it was 2 to 3 years post injury. I apologize, I don't have it right off the top of my head, but he had been home for a good while. The residual limb was fully healed, so he was definitely more in the routine of the, in theory and time,
Mm-hmm.
was more in the routine of dealing with his situation. But I think because of his isolation at home, because of his just lack of resources, I don't think he had really moved through the actual recovery process.
For sure.
And honestly, he still is moving through the recovery process. I don't want to make it sound like because he came here, he's totally good to go. That's why we still have the tele-rehab in place. And so, but yeah, he was definitely more into the recovery than some of our folks.
Okay. And then, did he lose his hand completely in the accident? Was there any surgery, like any parts surgically removed post accident? And would plan be significantly different if accident caused a total amputation?
Yeah, so back to his diagnosis. So basically, if you think about his hand, fingers 2, 3, and 4 were basically amputated. And so he had like his use of his palm, he had a little bit of his thumb left over. And so he could do like almost an opposition grasp. And so that was really why our clinicians were able to get a bit more function because he was able to pick up things, and we worked on some fine motor stuff with him. Um, as a result, the device that he was using really only allowed almost like a tenodesis grasp. And so it just wasn't super functional for some fine motor things, and it was just a bit cumbersome to use. Um, but again, I think what was the biggest impact is that we helped Yoni work through the emotional factor of like, I don't need that device. I can still be really functional with my hand the way that it actually sits today. And I think some people just, they need a little bit of recalibration along those lines.
And I think what's interesting too is that's years post,
Yeah.
right?
Yeah.
So I think that's the importance of, I wanted to touch on this. I'll touch on it now, but just like the ego of maybe a local prosthetist and saying, no, I think the recommendation is just give them a more expensive device,
Yeah.
a newer device. Really, you peel back the layers and you sit down and you fully understand his complete situation, and say like, well, no, there's other things that may lead to him being more successful and motivated than
Hmm.
just a new fancy device.
Yeah. Totally agree. And then just to, um, if the amputation was more severe, um, I think that it would have looked differently because we would have had to figure out how does he use the device more effectively, and does he need multiple devices? I think that's always a big question. As to a lot of the feedback we get is those mechanical, pretty basic devices are actually more functional for people, but those newer myoelectric devices are it's technology, so it's new and shiny and fancy and it looks cool. There's definitely some benefit to it, but they aren't the most durable. They're definitely more expensive, and functionality wise, they're not all that versatile. So I think we would have had to work through some of those decisions a bit more if he was more appropriate for something like that, or if it was just more of a severe, let's say above wrist or above elbow type of situation.
And then just a quick reminder, keep asking questions. These are great.
Yeah, it makes it more fun because I
Steve
don't
and I
have to
both
talk the whole
appreciate
time.
that. That's right.
Taylor is in the background here, hoping that I don't talk as much too. So, all right, moving on to the next one. So, I should have probably put the therapy approach at the very top because it seems almost easier to talk about that way. But this gentleman, Lane, actually has only participated in our tele-rehab program. So I think that's another thing to mention is you don't have to go through our inpatient program in order to access tele-rehab, and these processes aren't linear in nature. So you could again bounce back from one or the other, or someone could just decide to go through that stage 2 pre-prosthetic phase with our tele-rehab program and do the rest of their therapy locally. So I guess as you guys might be thinking about how to make decisions on referrals, if that would be the case, we can be pretty flexible with that, and really just want to jump in and be helpful to the best of our ability and at whatever phase makes sense. So this gentleman happened to be in phase 4. He actually is pretty complex. So he had a left upper extremity amputation and a left above knee amputation. And then on top of that, he had a right median and ulnar nerve palsy. And so that happened as a result of an electrical fire at work. And so again, this gentleman is extremely young, lives at home with his wife, but came to us actually due to COVID because he was confined to his home. And so traditionally he was, or prior to getting to us, he was participating in more traditional therapies, OT and PT at a clinic. As I was talking to our OT about this particular situation, one of the things that really stuck out to me is that he reported doing a lot of mass practice type of activities. So using the body powered and the myoelectric prosthesis you see there, using those two prosthetics, he was doing things like fine motor and grasp and things like that with the goal of some functional activities. But what they were finding was it didn't translate. And he ended up being frustrated because he would be doing these. It didn't translate, and he couldn't really connect why he was doing that. And it's really interesting once you are working with an individual and you're having them do an activity, and then as a clinician you see on their face that they have no clue why they're doing the activity. It actually happened to me the other day. It wasn't an amput. I wasn't working with someone with limb loss, but we did the activity. I was working on standing and reaching, and he looked at me and said, "I don't understand why I'm doing this." So it was a really good feedback for me to say, like, well, everything that we're doing, I have to make sure that they know exactly why. And for this gentleman, that was missing. And that's been a really big gap that we've been able to fill. So his therapy goals, he wants to be independent with the completion of his ADLs, and specifically, taking on and off his socks, some adaptive genes. He wants to complete some simple stovetop meal prep. The left prosthetic liner, you'll see a video on this in addition to the genes, but that's been a really big challenge for him, and trying to figure out how to do that, as well as some house chores and mowing the lawn. The other thing that's happened is he came to us without any involvement from a psychologist, and this has actually been a referral that we've sent to a psychologist local, to a telerehab psychologist associated with QLI, because he was just getting really frustrated and having a hard time envisioning what life was going to look like as he's just in the middle of all this kind of stuff that he's dealing with. And so that was something that came out of working with him, getting to know him, and understanding really what he needed to be successful. So these are the therapy goals. What we're going to do is show you two videos. And I apologize, the video quality isn't terrific. Some of it we're depending on. It got blown up, and as we were putting this together, we just tried to get a couple of good videos that made a little bit of sense. There's no sound, so I'll talk you through what's going on. But this first video, he's actually standing on he's standing, and you can see he's got a mechanical prosthetic on that left side. And Mel is working with him. You don't see Mel, but this is a virtual session, so Mel can actually see what he's doing. You guys are actually from the perspective of Mel, and she's working with him on strategies to take and put the button in and out of his genes. Now, granted, we're missing some specificity with this from a learning perspective, because the better way to do this would be, actually on his body, but he's not quite ready for that. So Mel was working through, and you can see it cut out to her. So she's giving him some cues and some directions. It's going to cut back into it here as well. But she's giving him some verbal cues and some strategies to work through this. And the next step will be, to actually put them on, and try it, while he's standing or while he's sitting, or however they're going to do this next. So, the clinicians have gotten really good at providing verbal cues. Mel is actually really good at, doing some therapies right alongside them. So it's pretty common that, she'll go down into the kitchen here at QLI and cook with them. So they'll be cooking in their kitchen, she'll be cooking in our kitchen, and she can demonstrate and show them what's going on and what she wants them to do, from maybe a strategy standpoint, from a sequencing standpoint, that sort of thing. So our clinicians have gotten really creative, for a couple of reasons. One, it's more engaging for the client, but it's also more engaging for our clinicians. Our clinicians are just not built to be sitting in front of a screen. So we're really encouraging them to find ways to engage themselves in some of this therapy. And so that's been really cool to see them do that. And so this next video you're going to see, he's trying to put on his sock liner, and he does have his left prosthetic on. And actually, we were just talking about this one in the office yesterday. I think what Mel's probably going to do is have him try this without his prosthetic on, because he's having a hard time. You'll see he's having a hard time gripping the prosthetic or gripping the liner with his hook. So Mel, again, is talking him through, helping him work on some strategies and that sort of thing. But again, this will probably be progressed the next time that they work together, just because he's getting pretty frustrated with this. You can see he can kind of get it started, but there's no grip on that left-hand side with the hook. So what we think we're going to probably do is he'll have a little bit more grip with just his skin. The thing that impacts this is he's got some sensitivity too, and so he's got a little bit of pain and discomfort. So we're having to figure out the best way to do that. But really, the impact for Lane is that, honestly, he can do this on his own. Right now, his wife's having to help him. And so this independence factor is really huge. The other thing that I'll mention on the functionality of the therapy is that Mel and Lane are actually going to work on mowing the lawn. And so this wasn't something that they even had considered at an outpatient clinic. If they had considered it, there's really no way that they could have practiced it probably. But B, you know, all of those fine motor things that they were doing wouldn't have translated to this, because being able to position the mower, depending on the type of mower, he'd have to pull the cord of the mower, right? If you think about and envision all the things that it takes stepwise to do that, and then you take someone with a lower extremity amputation and then bilateral upper extremity involvement, and how does that all play out? That becomes a really complex task. So, and that's something that we're able to see, and a small example of all the things that we start to address once we see them in their environment. And we talk to Lane and say, like, what are the things that would bring you most value and you find most meaningful? I'll tell you, I wouldn't want to be mowing the lawn probably, because I hate mowing the lawn. But I suppose if it was taken away from me, I might feel a little bit differently about it. So it's pretty interesting to hear them talk about the things that they miss. And usually they're things that we take for granted. So hopefully I'd be able to pay someone to mow my lawn, but
I'm training my
good for
4-year-old
Lane.
training my 4-year-old daughter. I told her she has 1 year and then she's up. No, just kidding.
I know my son asked to mow the lawn the other day, and he's 8. And I'm like, you know what, bud? You're probably going to ask to mow the lawn one time.
Yeah,
You're going to
exactly.
mow it, and then you're going to ask not to mow it. And then I'm going to have a decision to make. But in all seriousness, I mean, it's a really engaging thing
Absolutely.
for many of our individuals. And I think um, probably if I was in their position too, you know, anything that gave me a sense of, um, you know, purpose
Yep.
and feeling like I could accomplish something, that's a pretty cool feeling. So it is really cool to watch them.
My wife and I are fighting over who gets to mow the yard right now because it's the only time we get a break from our kids. So that is a fact. We have a lot of questions that came in. Good questions. Do you have anything else to move on
I don't.
prior to? Okay.
And I have plenty of time for questions. So like
That's
double
right.
win.
All right. So let's start with this one here. So as an insurer, we often see these cases to deal with for the remainder of the injured worker's life. For Lane, what would you anticipate long term? Are there typical problems these individuals experience? Is there an average lifespan for a prosthetic device? Are the person's ages, as the person ages, would another visit to say Omaha to QLI or to a facility to talk about life changes be prudent?
Loaded question,
I
Tim.
know.
So that last part, I think, is probably the easiest place to start. I do believe that, well, this probably goes philosophically for how we look at things at QLI. We believe that learning, regardless of your injury, brain injury, spinal cord injury, amputee, whatever the case may be, that learning happens for a long period of time and doesn't stop, as long as you provide an environment and challenges in order to facilitate that. And so obviously, as people move through and they age, as they learn and grow, and start to, you know, I think accommodate to their new identity of having an amputation, then I think their capabilities grow, their willingness to try things grows. But again, the aging factor, right? Their abilities might actually decline, and so they may need different accommodations. So I really believe, and this goes back to what I said earlier, that this is not a linear process. This isn't you go through phase 1, 2, 3, and 4, and then you're done and graduate. I believe that you probably go through phases 1 and 2, and then 3 and 4, you could bounce back between those indefinitely. And I think if you go into this with a finite attitude, I think you're probably going to end up with some bigger challenges. And so, you know, to be honest, with our tele-rehab program, what we've seen is we have lots of our payers saying like, hey, this has been really great, but can you stay on board with them just once a month for 30 minutes to check in and be proactive about this? And I think that's a really insightful decision to make. It requires a lot of trust, I think, in an organization to say like, hey, we don't think that you're going to take advantage of this. But it does allow us to check in and make some recommendations and just keep people going, rather than maybe depending on a boot camp of something like that. And again, that might still be important and something that's needed, but I think a proactive approach with this. As far as like the length of time, let's see how good my memory is here. The length of time for prosthetics, I think, depends on the type of prosthetic. Those really extensive and intricate myoelectric ones, what we've heard is they have a lifespan of 2 to 5 years. I think it depends on how well they're taken care of. It depends on what they're using them for. It depends on a lot of factors. As far as those mechanical ones, they're pretty durable. So the fit probably is the one that might change, right? You might have someone lose some circumferential girth of that residual limb, so that might require a socket change of some sort. Same with the lower extremity one, so socket changes. But I think that 3 to 5 years is probably a safe bet, but knowing that how people use them and what they do with them definitely affects that. What did I miss?
No, you pretty much you talked about the anticipate what they should anticipate long term in your first answer. Um, any typical problems? So, like, is there any you know anything that could come from the use of a prosthetic, or you know,
I think skin is always something to think about, right? So again, as someone ages or as someone grows in their ability or has a different level of activity, be it more activity or less activity, I think how the fit of the socket and what the skin health looks like is something to keep an eye on. And so that's always, I think, a moving target. I think, again, back to the aging, I think strength and flexibility are huge with these individuals. If we can maintain that, I think their function stays high. I think it helps with some of the skin issues. And then just overall activity level. What we know is that when people are active, they're more healthy physically and they're more healthy emotionally. And so if we can find ways to keep them engaged in purposeful activity that is meaningful and engaging, then I think the overall outcome is better. So again, I've repeated that probably 100 times, but we know that if we tie all of these physical goals to something that's of purpose, that there's a really great outcome. And that's not any different than what it is for you and I today, right? If you think about how we're dealing with just the COVID restrictions and constraints, we're probably all dealing with those in a different way, but we're all going back to something that we find purpose in to give us hope and optimism on what's going to be on the other side of this. And so, be it a limb loss situation, a brain injury, a spinal cord injury, or put ourselves in whatever situation you want, such as COVID, like we all have that in common. And so I think that is something that I find A, really interesting because we're really no different in that way, but B, something that is a big job for all of our clinicians and for our teams to make sure that we tie it to something bigger than just walking or just being able to put our pants on or just being able to put the liner of our prosthetic on. So
definitely. Thank you for that question. That was a great question. Let's start here. And I will be launching the poll here in just a few minutes, so please hang in there for those wondering when that is going to be launched.
yeah.
Very important to differentiate between the treatment and care of upper limb prosthetics and lower limb prosthetics. Can you comment on our methods of care when treating a lower limb versus an upper limb?
Hmm. Good question. Um, I don't know that I have. I guess I wish that I could have the opportunity to ask, like, what do you mean by that question? So I'll do my best to answer
Well, right now it's
it.
an anonymous. If you do want to discuss that question more,
And
you have Steve's contact information. Please reach out to
yeah,
him.
admittedly, there's definitely a difference between the two. Um, I think and there's a difference whether it's like, let's just say lower extremity, if it's above knee or below knee. Above knee are way more complex than below knee. And same with upper extremity, like where the amputation takes place definitely has an impact on how we address it and the complexity of it. So we definitely see them as different. I guess maybe in how they're the same. We don't say a person with an upper extremity amputation only sees OT and a person with a lower extremity amputation only sees PT. Our PTs and OTs are very um, collaborative and they work on both of those. And so, and maybe that doesn't answer the question, but to me, like that's what's not different. is that the OT has to understand, can this person stand, and like the mechanics of alignment and that sort of thing of the lower extremity, just like the PT has to understand like what's the strength of the shoulder girdle and all of that with the upper extremity.
Is
So
that something that would differentiate us from maybe an outpatient setting,
the
or?
I mean, I think if you go to an outpatient setting and you have somebody with an upper extremity amputation, they're likely going to go to an OT,
Okay.
a certified hand therapist or something like that, and then the lower extremity is going to go to a PT. So again, I'm probably missing the question behind the question on this, so that's the best I can answer with the context that I have.
Okay. Can you talk a little bit about billing? So how does billing work with all these services and clinicians? So I think just kind of go back to maybe what we.
So on the day program, it's billed. If you're familiar with QLI, it's billed on a per diem. So you show up for your day program, we charge you X amount per day, and all of the therapies, all of the awesome stuff that happens while they're here is included. And so there's no really need to worry about like, hey, am I going to get nickel and dimed for an off-campus trip or an extra therapy session or something like that. On the tele-rehab side, it's really billed on a fee for service. Um, Up to this point, we had really only one CPT code that we were billing. But as telemedicine and telerehab is becoming more of a focus, we're getting pushed to transition to more of a traditional CPT code type of situation, which we've responded to. So it's billed just like you would see at an outpatient clinic. It just happens to happen virtually over, um, you know, FaceTime, or it's not FaceTime, but we do it through Zoom. So it just happens virtually.
Okay. And I did just launch the poll question, so please answer that. Um, we're kind of excited for it. We've been throwing around this
This will be
idea.
interesting to see
Yeah,
what
we've
the
been
group
throwing on the
wants.
idea of doing a little podcast style discussion just on some things like conflict, perseverance, influencing others, things that would help individuals, not just in the workers' compensation space, but just throughout everyone's individual lives. We have some amazing clinicians and individuals that really do specialize in these types of things, and so we thought bringing them in for a little podcast style. No CEUs will be offered for those types of things, but more laid back, just a casual conversation style. So I'm actually excited about the numbers we're getting right now. So
Maybe you get a little bit more humor or something instead of the CEU. I don't know. I don't know how we.
yeah, there's no humor in this at all. This has been terrible. We did have, Steve, this is a record for you. We had 375 people on today.
Ooh, PR.
That's right. PR. We keep breaking those. We had Dr. Snell had
Yeah, I'm no
557.
Dr.
So
Snell. He's way smarter than I am. Way better looking.
true to all the above.
Probably a better presenter too. It's probably not even a question.
I won't comment on that one. We did have another question, Steve. Can you talk about the age range that we've seen? Someone just made a comment about the case studies being younger.
Yep.
What
Yep.
are we seeing?
Yeah, good question. The age range has really varied. Obviously, these guys are on the younger side. We have it varies from it's a similar age range as what we have for our QLI program, so roughly 18 to 65. So definitely a middle-aged individual, on average around low 40s, upper 30s. But yeah, I apologize. It probably gives a different impression just because I chose a couple of situations that were two young guys. So I can think of a guy right now who's in our tele-rehab program. He's this is actually a cool story. So he's in his 60s, but he's an event promoter, and he has a bilateral lower extremity amputation. And the reason we're doing tele-rehab is that he travels around the country and has to like set up all of the music venues, and he was having a hard time like behind the stage because it was dark and there's cords, and he was having to step over all this stuff. And also he wasn't able to get the therapy because he traveled so much.
Mm-hmm.
And so the tele-rehab was a really great option because it was mobile and convenient for him. But again, we could see what the environment looked like on the job and help make recommendations about what to do with cords or lighting or whatever the case may be. So he's on the older age spectrum, but also just a really cool and pretty interesting situation. The other thing is just emotionally, he has two kids and was really struggling with that. So our psychologist was kind of on the road with him too.
Just ended the poll. If you didn't see that, please just feel free to reach out to us. QLI webinars at qliomaha.com.